Hello class, welcome to the recorded lecture on Chapter 22, Psychiatric Emergencies. After students complete this chapter and the related coursework, they will be able to recognize behaviors that pose a risk to the EMT, patient, or others and understand the basic principles of the mental health system. Additionally, students will have the knowledge and the skills to successfully assess and manage patients experiencing a psychiatric emergency within the legal parameters of their scope of practice. Introduction. EMTs often care for patients experiencing a behavioral crisis or psychiatric emergency. The crisis may be a result of acute medical situation, mental illness, mind-altering substances, stress, and many other causes. Myth and reality. At some point, most people experience an emotional crisis. This does not mean that everyone develops mental illness. Otherwise, healthy people may sustain acute or temporary mental health disorders. Do not jump to conclusions that a patient is mentally ill when exhibiting behaviors discussed in this chapter. The most common misconception about mental illnesses is that if you are feeling bad or depressed, you must be sick. There are many justifiable reasons for feeling depressed, such as divorce, death of a relative or friend, and many others. Many people believe that all individuals with mental health disorders are dangerous, violent, or otherwise unmanageable. Only a small percentage of people with mental health problems fall into these categories. EMTs may be exposed to a higher proportion of violent patients because they are seeing people who are, by definition, considered to be having a behavioral crisis. Communication is the key. In some cases, patients will de-escalate when the level of trust is established. Although you cannot determine what has caused a person's crisis, you may be able to predict whether the person will become violent. Defining a behavioral crisis. Behavior is what you can see of a person's response to the environment, his or her actions. Most of the time, people respond to the environment in a reasonable way. Over the years, people learn to adapt to a variety of situations in daily life, including stress. Sometimes a stress is so great that the normal ways of coping are not enough, or the person uses negative coping mechanisms such as withdrawal, drugs, and alcohol. Reactions to stress that are acute and those that develop over time can create a crisis. The change in behavior may be considered inappropriate or not normal by the person who calls 911. A behavioral crisis or psychiatric emergency includes patients of all ages who exhibit agitated, violent, or uncooperative behavior or who are a danger to themselves or others. EMS is called when the behavior has become unacceptable to the patient, family, or community. A patient may have dementia or depression, behavior that may interfere with activities of daily living. Chronic depression, a persistent feeling of sadness and despair, may be a symptom of a mental health disorder. Usually, if an abnormal or disturbing pattern of behavior lasts for a month or more, it is a matter of concern from a mental health standpoint. When a psychiatric emergency arises, the patient may show agitation or violence, may become a threat to self or others. The magnitude of mental health disorders. According to the National Institute of Mental Health, mental disorders are common throughout the United States, affecting tens of millions of people each year. A psychiatric disorder is an illness with psychological or behavioral symptoms that may result in impaired functioning. Anxiety disorders are among the most common mental health disorders. Generalized anxiety disorder, panic disorder, social and other phobias, post-traumatic stress disorder, PTSD, obsessive-compulsive disorder. The U.S. mental health system provides many levels of assistance to people with psychological conditions. Professional counselors are available for marital conflicts and parenting issues. More serious issues, such as clinical depression, are often handled by a psychologist. Some of the most severe psychological conditions, such as schizophrenia and bipolar disorder, require a psychiatrist to prescribe medication. Most psychological disorders can be handled through outpatient visits. Some people require hospitalization in specialized psychiatric units. Psychiatric disorders have many underlying causes: social and situational stress, such as divorce or death of a loved one, diseases such as schizophrenia, physical illness such as diabetic emergencies, chemical problems such as alcohol or drug use, biological disturbances such as an electrolyte imbalance. Sometimes these conditions are compounded by non-compliance with prescribed medication regimens. Pathophysiology. An EMT is not responsible for diagnosing the underlying cause of a behavioral crisis or psychiatric emergency. You should understand the two basic categories of diagnosis a physician will use: organic, physical, or functional, psychological. Organic disorders. Organic brain syndrome is a temporary or permanent dysfunction of the brain caused by a disturbance in the physical or psychologic functioning of the brain tissue. Causes: sudden illnesses, traumatic brain injury, seizure disorder, drug and alcohol abuse, overdose or withdrawal, diseases of the brain such as Alzheimer's disease and meningitis. Altered mental status can arise from hypoglycemia, hypoxia, impaired cerebral blood flow, hyperthermia, and hypothermia. In the absence of a psychologic cause, altered mental status may be an indicator of a psychiatric disorder, such as bipolar disorder. Functional disorders. A functional disorder is a psychological disorder that impairs bodily function when the body seems to be structurally normal. Examples include schizophrenia, anxiety conditions, and depression. The chemical or physical basis of these disorders does not alter the appearance of the patient. Safe approach to behavioral crisis. All regular EMT skills, patient approach, assessment, patient communication, obtaining a history, and providing care are used in a behavioral crisis. Other management techniques are also involved. Follow the general guidelines listed in Table 22.1 to ensure your safety at the scene of a behavioral crisis or psychiatric emergency. Assess the scene, ensure you have a means of communication, know where the exits are, don personal protective equipment, have a definite plan of action, urgently de-escalate the patient's level of agitation, and calmly identify yourself. Be direct, be prepared to spend extra time, stay with the patient, do not get too close to a potentially violent patient, express interest in the patient's story, avoid fighting with the patient, be honest and reassuring, and do not judge. Patient assessment. Scene size up. Scene safety. The first things to consider are the scene safety and the patient's response to the environment. Is the situation potentially dangerous for you and your partner? Do you need immediate law enforcement backup? Should you stage until law enforcement personnel have secured the scene? Does the patient's behavior seem typical or normal for the circumstances? Are there legal issues involved, crime scene, consent, refusal? Take appropriate standard precautions and request any additional resources you may need, law enforcement, additional personnel, early. Mechanism of injury, nature of illness. Determine the mechanism of injury and or the nature of illness. Note any medications or substances that may contribute to the complaint or that may be for treatment or relevant medical condition. Primary assessment. Form a general impression. Begin your assessment from the doorway or from a distance. How does the patient appear? Begin with an introduction of who you are and let the patient know that you are there to help. Perform a rapid physical exam. Look for trauma, especially head trauma. Observe the patient closely. Use the AVPU scale to check for alertness. Establish a rapport with the patient. Most medical or trauma situations will include a behavioral component. Treat the whole patient, the behavioral component as well as the medical or traumatic issue. Airway and breathing. If your patient is in physical distress, assess the airway to make sure it is patent and adequate. Evaluate the patient's breathing and obtain the rate and effort. Use the pulse oximetry if available. Provide the adequate interventions based on your assessment findings. Circulation. Assess the pulse rate, quality, and rhythm. Evaluate for the presence of shock and bleeding. Assess the patient's perfusion by evaluating skin color, temperature, and capillary refill. Transport decision. Unless the patient is unstable from a medical problem or trauma, prepare to spend time with the patient. It may take time to gain the patient's trust. History taking. Investigate the chief complaint and then obtain a sample history. Consider 3 major areas as possible contributors. Is the patient's central nervous system functioning properly? Are hallucinogens or other drugs or alcohol a factor? Are significant life changes, symptoms, or illness caused by mental rather than physical factors involved? Sample history. You may be able to elicit information not available to the hospital staff. Ask about previous episodes, treatments, hospitalizations, and medications related to the behavioral problems. In geriatric patients, consider Alzheimer's disease and dementia as possible causes of abnormal behavior. Determine the patient's baseline mental status to guide treatment and transport decisions. This information will also be extremely helpful to hospital personnel. Obtain information from relatives, friends, observers, and caregivers. Your assessment of the situation has 2 primary goals: recognizing major life threats, reducing the stress of the situation as much as possible. Use reflective listening to gain insight into the patient's thinking. Repeat in question form what the patient has said. This encourages the patient to expand on their thoughts. The table on this slide lists the questions to ask in evaluating a mental health disorder. Secondary assessment. Physical examination. In an unconscious patient, begin with a physical exam to look for a reason for the unresponsiveness. Rule out trauma, especially to the head. Conduct a detailed physical exam and obtain a complete set of vital signs. Obtain vitals only if it is possible to do so without worsening the patient's emotional condition. Make every effort to assess blood pressure, pulse respirations, skin, and pupils. Consider whether prior events such as physical agitation, use of stimulants, alcohol withdrawal, or taser exposure may be contributing to the patient's condition. When examining a patient with a behavioral emergency, check for track marks indicating drug abuse and for signs of self-mutilation. A conscious patient may not respond to your questions. You can tell a lot about a patient's emotional state from facial expressions, pulse rate, and respirations. Tears, sweating, and blushing may also be significant indicators of state of mind. Look in the patient's eyes. A blank, glazed, or rapidly moving eyes may mean the patient is experiencing central nervous system dysfunction. Transport decision. When available, have law enforcement personnel or firefighters accompany you in the back of an ambulance during transport. There may be a specific facility to which the patients with psychiatric emergencies are transported. Transport by ground rather than by air. Try to make the patient comfortable placing the stretcher in Fowler's or high Fowler's position. Helps prevent aspiration and reduces physical exertion. Reassessment. Never let your guard down. Many patients experiencing a behavioral crisis will act spontaneously. Be prepared to intervene quickly. If restraints are necessary, reassess and document the patient's respirations as well as pulse, motor, and sensory function in all restrained extremities every 5 minutes. Interventions. Your heart may go out to an emotionally distressed patient. There is often little you can do during the short trip you will be treating the patient. Your job is twofold: diffuse and control the situation, safely transport the patient to the hospital. Intervene only as much as it takes to accomplish these tasks. Be aware of standard precautions. If you encounter a situation where you think a pharmaceutical restraint may be necessary, request ALS as early as possible. Communication and documentation. Give the receiving hospital advance warning when a patient experiencing a psychiatric emergency is arriving. Many hospitals require extra preparation to ensure the appropriate staff and rooms are available. Report whether restraints will be required when the patient arrives at the hospital. Communicate to the hospital the things you observe at the scene that may help to explain the patient's situation, such as observed behaviors or medications. Document thoroughly and carefully. You may be the only documentation about the patient's distress. Psychiatric emergencies are fraught with legal dangers, so document everything that occurred on the call, particularly in situations that required restraints. If restraints are used, say which type and why they were used. Acute psychosis. Psychosis is a state of delusion in which the patient is out of touch with reality. Affected people live in their own reality of ideas and feelings. Causes of psychiatric episodes: mind-altering substances, intense stress, delusional disorders, schizophrenia. Some episodes last for brief periods, others last a lifetime. Schizophrenia. Schizophrenia is a complex disorder that is not easily defined or easily treated. The typical onset occurs during early adulthood, with symptoms becoming more prominent over time. Influences thought to contribute to the disorder: brain damage, genetics, psychologic and social influences. Symptoms: delusions, hallucinations, a lack of interest in pleasure, erratic speech. Guidelines for dealing with a psychiatric patient. Determine if the situation is dangerous. Clearly identify yourself. Be calm, direct, and straightforward. Maintain an emotional distance. Do not argue. Explain what you would like to do. Involve people whom the patient trusts, such as family or friends, to gain the patient's cooperation. Excited delirium. Delirium is a condition of impairment in cognitive function that can present with disorientation, hallucinations, or delusions. Agitation is a behavior characterized by restless or irregular physical activity. Although patients experiencing delirium are generally not dangerous, if they exhibit agitated behavior, they may strike out irrationally. In such cases, your personal safety must be considered. Symptoms: hyperactive, irrational behavior, vivid hallucinations, hypertension, tachycardia, diaphoresis, and dilated pupils. If you think you can safely approach the patient, be calm, supportive, and empathetic. Be an active listener by nodding, indicating understanding, limiting your interruptions of the patient's comments. Approach the patient slowly and purposefully, and respect the patient's personal space. Limit physical contact as much as possible. Do not leave the patient unattended. Use careful interviewing to assess the patient's cognitive functioning. Try to indirectly determine the patient's orientation, memory, concentration, and judgment. Pay particular attention to the patient's ability to communicate clearly and make notes on the patient's apparent mood. Pay attention to the patient's appearance, dress, and personal hygiene. If the patient appears to be experiencing an overdose, take all medication bottles or illegal substances with you to the medical facility. The patient should be transported to the hospital with psychiatric facilities. Whenever possible, refrain from using lights and sirens. If the patient's agitation continues, request ALS assistance so chemical restraint can be considered. Uncontrolled or poorly controlled patient agitation can lead to sudden death from sudden cardiopulmonary arrest, physical agitation thought to result from metabolic acidosis, physical control measures including tasers, positional asphyxia, which occurs when the patient's physical position restricts chest wall movement or causes airway obstruction. Restraint. Pre-hospital patient restraint reduces the possibility of patient injury, the potential for injury to the EMS providers, and allows for safe and appropriate treatment of an uncooperative patient. The National Association of Emergency Medical Services Physicians recommends that every pre-hospital care transport provider create and follow a pre-hospital patient restraint protocol. Such protocols consider the appropriateness of restraint, the types of restraints, the care provided to a patient following restraint. Your protocol must consider the laws of your state. There is wide variation in pre-hospital patient restraint protocols throughout the country. Protocols should include only the use of restraint devices that have been approved by the state health department or local EMS agency. Soft restraints include sheets, wide wristlets, and chest harnesses. Hard restraints include plastic ties, handcuffs, or leather restraints. The method of restraint chosen should be the least restrictive method that will ensure the safety of the patient and providers. Risk associated with patient restraint. Personnel must be properly trained in the use of restraints. If you restrain a person without authority in a non-emergency situation, you expose yourself to the possible lawsuit and to personal danger. Legal actions against you can involve several types of charges: assault, battery, false imprisonment, violation of civil rights. You may also use restraints only to protect yourself or others from bodily harm or to prevent the patient from injuring himself or herself. You may use only reasonable force as necessary to control the patient. Follow local protocols and your company's pre-hospital restraint policy, and consult medical control if needed. You should always involve law enforcement personnel if you are called to assist a patient in severe behavioral crisis or psychiatric emergency. Law enforcement personnel will provide physical backup in managing the patient, serve as the necessary witness and legal authority. A patient who is restrained by law enforcement personnel is in their custody. Before you consider physical restraint, use verbal de-escalation techniques to avoid the need for physical restraint. Consider asking the family to assist you in calming the patient. Be honest and straightforward and talk in a calm, friendly tone. The process of restraining a patient. Once the decision has been made to restrain a patient, you should carry it out quickly. Make sure you have adequate help to safely restrain the patient. Ideally, 5 people should be present to carry out the restraint, 1 responsible for each extremity and 1 responsible for the head. There should be a team leader who directs the process and the plan of action before you begin. Use the minimum force necessary to control the patient. The level of force will vary depending on the following factors: the degree of force that is necessary to keep the patient from injuring self or others, patient's size, sex, strength, and mental status, including the possibility of drug-induced states, the type of abnormal behavior the patient is exhibiting. You or your partner should talk to the patient throughout the process. Treat the patient with dignity and respect at all times. If possible, a provider of the same gender should attend to the patient. Wear appropriate barrier protection during patient restraint activities. Avoid direct eye contact and respect the patient's personal space until necessary. Never leave a restrained patient unattended. 4-point restraints, both arms and both legs, are preferred for uncooperative patients. Do not place anything over the patient's face, head, or neck. If the patient is spitting, a surgical mask may be placed loosely over the patient's mouth. If the patient attempts to bite, a hard cervical collar may be placed at the patient's neck. Respiratory and circulatory problems have been known to occur in combative patients who are restrained. Monitor the patient for vomiting, airway obstruction, respiratory status, circulatory status, changes in level of consciousness, reassess airway and breathing continuously, and make frequent checks of circulation. Restraints applied in the field should not be removed until the patient is evaluated at the receiving facility. Performing patient restraint. Follow the steps in Skill Drill 22-1 to implement a 4-point restraint. A 2-point restraint technique is an option if allowed per local protocols. Once a patient has been restrained, reassess airway and breathing and document the information. The potentially violent patient. Violent patients make up only a small percentage of patients undergoing a behavioral or psychiatric crisis. However, the potential for violence is always a critical consideration for you as an EMT. Assess the level of danger based on the following risk factors. History. Has the patient previously exhibited hostile, overly aggressive, or violent behavior? Posture. How is the patient sitting or standing? Is the patient tense, rigid, or sitting on the edge of his or her seat? The scene. Is the patient holding or near potentially lethal objects such as a knife, gun, glass, poker, or bat, or near a window or glass door? Vocal activity. Which kind of speech is a patient using? Loud, obscene, erratic, and bizarre speech patterns usually indicate emotional distress. Physical activity. The motor activity of a person undergoing a psychiatric emergency may be the most telling factor of all. A patient requiring careful watching is one who has tense muscles, clenched fists, or glaring eyes, is pacing, cannot sit still, is fiercely protecting personal space. Other factors to consider. Poor impulse control, a history of truancy, fighting, or uncontrollable temper, history of substance abuse, depression, which accounts for 20% of violent attacks, functional disorder. If the patient tells you voices are telling him or her to kill and believe it. Suicide. Depression is the single most significant factor that contributes to suicide. It is a common misconception that people who threaten suicide never commit it. Suicide is a cry for help. Threatening suicide is an indication that someone is in a crisis that he or she cannot handle alone. Immediate intervention is necessary. Be alert to these warning signs. Does the patient have an air of tearfulness, sadness, deep despair, or hopelessness that suggests depression? Does the patient avoid eye contact, speak slowly or haltingly, project a sense of vacancy as if he or she really is not there? Does the patient seem unable to talk about the future? Is there any suggestion of suicide? Does the patient have any specific plans related to death? The table on this slide lists the risk factors for suicide. Consider the following additional risk factors for suicide. Are there any unsafe objects in the patient's hands or nearby? Is the environment unsafe? Is there evidence of self-destructive behavior? Is there an imminent threat to the patient or others? Is there an underlying medical problem? Are there cultural, religious, or social beliefs prompting suicide? Has there been trauma? A suicidal patient may be homicidal as well. If you believe you are in danger, obtain police intervention. The most important service you can provide for a suicidal patient is compassionate transport to a medical facility where the patient can receive proper treatment. Post-traumatic stress disorder and returning combat veterans. PTSD can occur after exposure to or injury from a traumatic event. Example events: sexual and physical assault, child abuse, serious accidents. Natural disasters, war, loss of a loved one, stressful life changes. PTSD is not necessarily the result of one isolated or recent event. An estimated 7% to 8% of the general population will experience signs of PTSD at some point in their lives. Military personnel who have experienced combat have a high incidence of PTSD. Reminders of their experiences in the military from news coverage or gatherings of veterans can also be triggers. Signs and symptoms of PTSD. Symptoms of PTSD include feelings of helplessness, anxiety, anger, and fear. People with PTSD may avoid things that remind them of the trauma, including loud noises or smells, and sometimes avoid interactions with other people. Suffer constant nervous system arousal that is not easily suppressed. Heart rate increases, pupils dilate, and systolic blood pressure increases. Senses are sharpened and mental acuity is heightened. The victim may be hypervigilant or display an exaggerated startle response to perceived danger. Can relive the traumatic event through intrusive thoughts, nightmares, or even flashbacks. Dissociative PTSD occurs when a person attempts to find an escape from constant internal distress or a particular disturbing event. Other psychologic conditions such as personality disorders and increased functional impairment can develop in individuals with this type of PTSD. Many veterans develop a host of adverse physical conditions, some from injuries from combat and sometimes from unfocused pain that is not associated with any specific body part. Combat veterans in particular may be prone to early heart disease, higher incidences of type 2 diabetes, loss of brain gray matter. Another consideration for the combat veteran is the higher incidences of traumatic brain injury, TBI, sustained from trauma secondary to the explosion of an improvised explosive device, IED. Symptoms may go undiagnosed for several reasons. Similarity to symptoms of PTSD. The patient may downplay the symptoms. Healthcare providers should eliminate excess noise, refrain from touching or doing anything to the veteran without an explanation, and keep their diesel equipment far away. Caring for the combat veteran. The returning combat veteran is a patient who will require a unique level of understanding, compassion, and specialized attention. Be careful how you phrase your questions. Use a calm, firm voice, but be in charge. Respect the veteran's personal space. Limit the number of people involved or move to a private and quiet space. Ask about suicidal intentions. Military personnel are trained to use weapons and are resourceful at improvising weapons. Ensure there is nothing the patient can access and use as a weapon. Physical restraint will not be effective with this population and may simply escalate the problem. If it is necessary to calm the patient, especially if there are safety concerns, chemical restraints administered by ALS should be considered. Medicolegal considerations. The medical and legal aspects of emergency medical care become more complicated when the patient is undergoing a behavioral crisis or psychiatric emergency. Legal problems are reduced when the patient consents to care. Gaining the patient's confidence is a critical task. Once you have determined that a patient has impaired mental capacity, you must decide whether he or she requires immediate emergency medical care. A patient in a mentally unstable condition may resist your attempt to provide care. Do not leave the patient alone. Doing so may result in harm to the patient or expose you to civil action for abandonment and negligence. request law enforcement personnel to handle the patient. Consent. Implied consent is assumed with a patient who is not mentally competent to grant consent. Consent matters are not always clear-cut in psychiatric emergencies. If you are not sure, request the assistance of law enforcement personnel or guidance from medical control. Limited legal authority. The EMT has limited legal authority to require or force a patient to undergo emergency medical care when no life-threatening emergencies exist. You should be familiar with your local and state laws regarding the situations. A competent adult has the right to refuse treatment, even if life-saving care is involved. In psychiatric cases, a court of law would probably consider your actions in providing life-saving care to be appropriate. A patient who is in any way impaired may not be considered competent to refuse treatment or transportation. Always maintain a high index of suspicion regarding the patient's condition. Assume the worst and hope for the best. Err on the side of treatment and transport. Carefully document the patient's statements and behavior to support your actions. Okay, class, let's go over some review questions. Review question 1. A behavioral crisis is most accurately defined as A severe acute psychiatric condition in which the patient becomes violent and presents a safety threat to self or others. B, any reaction to events that interferes with activities of daily living or has become unacceptable to the patient, family, or community. C, a normal response of the patient to the situation that causes an overwhelming amount of stress, such as loss of a job or marital problems. D, a reaction to a stressful event that the patient feels is appropriate but is considered inappropriate by the patient's family or the community. The correct answer is B. A behavioral crisis is any reaction to the events that interferes with the patient's activities of daily living or has become unacceptable to the patient or his or her family or the community. Not all patients with emotional crisis are psychotic, nor are all violent patients experiencing a psychiatric condition. These are common misconceptions. Various medical conditions can cause a behavioral crisis, such as hypoglycemia, hypothermia, and brain tumors. Answer A. This could be considered a symptom of a mental disorder. Answer B is the correct answer. Answer C could be normal behavior or a process to depression. And answer D, this could be normal behavior. Review question 2. Depression and schizophrenia are examples of A, functional disorders, B, altered mental status, C, behavioral emergencies, D, organic brain syndrome. The correct answer is A. Unlike an organic disorder, a functional disorder cannot be linked to any physical dysfunction or failure of an organ. Depression, schizophrenia, obsessive-compulsive disorder, OCD, and bipolar disorder are examples of functional disorders. They are usually caused by a chemical imbalance in the brain, not a structural or physical abnormality. Answer A is the correct answer. Answer B, altered mental status is a common presentation in patients with a wide variety of medical problems. Answer C, these are emergencies that do not have a clear physical cause and that result in abnormal behavior. Answer D, organic brain syndrome is a psychiatric disorder caused by a permanent or temporary physical change in the brain. Review question 3. When assessing a patient with a behavioral crisis, your primary concern must be A, allowing the patient to express himself or herself to you in his or her own words. B, setting your personal feelings aside and providing needed care. C, gathering the patient's belongings and taking them to the hospital. D, whether the patient will cause harm to you or your partner. The correct answer is D. There are many things that you should be concerned with when assessing a patient with a behavioral crisis, including all of the items listed as answers to this question. Your primary concern, however, must be the safety of yourself and your partner. Answer A, this is a good technique to use in assessment. Answer B, it is important not to allow your own prejudice to interfere with your treatment of the patient. Answer C, good patient skills are utilized in the treatment of every patient. Answer D is the correct answer. Review question 4. General guidelines to following when caring for a patient with a behavioral crisis include all of the following except A, being honest and reassuring, B, rapidly transporting the patient, C, having a definite plan of action, D, avoiding arguing with the patient. The correct answer is B. When caring for a patient with a behavioral crisis, the EMT must be prepared to spend extra time with the patient. It may take longer to assess and listen to the patients prior to transport. Answer A, this is part of proper treatment. Answer B is the correct answer. Answer C, this is also part of proper treatment. And answer D is also part of proper treatment. Review question 5. Reflective listening and assessment techniques used when caring for patients with an emotional crisis involves A, asking the patient to repeat his or her statements, B, simply listening to the patient without speaking, C, asking the patient to repeat everything that you say, D, repeating in question form what the patient tells you. The correct answer is D. Reflective listening, a technique in which you repeat in question form what the patient tells you, allows the patient to further expand on his or her thoughts. It also helps the EMT gain insight into the patient's situation. Answer A. This is considered to be a clarification of a response. Answer B. This is considered to be active listening. Answer C. Simplify and summarize the patient's response when the patient gives confusing or disorganized responses. D is the correct answer. Review question 6. Which of the following patients is at the highest risk for suicide? Answer A. A 24-year-old woman who is successfully being treated for depression. B. A 29-year-old man who was recently promoted with a large pay increase. C. A 23-year-old man who regularly consumes alcohol and purchased a gun. D. A 45-year-old woman who recently found out her cancer is in full remission. The correct answer is C. Situations or indications that place a patient at high risk for suicide include, but are not limited to, recent diagnosis of serious illness, financial setback, marital discard, death of a loved one, untreated psychiatric illness, recent acquisition of items that can cause death, such as a gun or knife, and chronic alcohol use. Question A. Answer A. A 25-year-old woman who is successfully being treated for depression. This woman is not at a high risk for suicide because she's successfully being treated. A 29-year-old man who was recently promoted with a large pay increase. This man is not at a high risk for suicide. Answer C is the correct answer. Answer D, a 45-year-old woman who recently found out her cancer is in full remission. This woman is not at a high risk for suicide. Review question 7. When caring for a patient with emotional crisis who is calm and not in need of immediate emergency care, your best course of action is to A. Advise the patient that he or she cannot refuse treatment. B. Leave the patient with a trusted friend or family member. C. Attempt to obtain consent from the patient to transport. D. Apply soft restraints in case the patient becomes violent. The correct answer is C. Just because a patient is experiencing an emotional crisis does not mean that he or she is mentally incompetent and cannot refuse EMS, transport, and treatment and/or transport. You should attempt to obtain consent from any conscious patient unless he or she clearly does not have decision-making capability, i.e., underage, altered mental status, or alcohol intoxication. Answer A. Do this only if the patient clearly does not have decision-making capacity. Answer B. Attempt to obtain verbal consent for transport to the medical facility. The correct answer is C. Answer D. Restraints are not often used in situations where a patient might become violent, but they are considered. Review question 8. When physically restraining a violent patient, the EMT should A. Continually talk to the patient as he or she is being restrained. B. Check circulation in all extremities only if the patient is prone. C. Remove the restraints if the patient appears to be calming down. D. Use additional force if the restrained patient begins to yell at the providers. The correct answer is A. When physically restraining a violent patient, the EMT or his or her partner should continually talk to the patient throughout the process. Treat the patient with dignity and respect regardless of the situation. Once the restraints are placed, they should not be removed even if the patient appears to be calm. Circulation in all extremities should be monitored regardless of the position in which the patient is restrained. A is the correct answer. Answer B. Always check the patient's extremities circulation often when physical restraints are applied, typically every 5 minutes. Answer C. Once restraints are applied, they should not be removed until the patient is evaluated by the hospital. Answer D. Only use the force necessary to initially restrain a patient. Review question 9. Upon arrival at the residence of a young male with an apparent emotional crisis, a police officer tells you that the man is acting bizarrely. You find him sitting on his couch. He is conscious but confused. He takes medications but cannot remember why. His skin is pale and diaphoretic, and he has noticeable tremors to his hands. You should first rule out A. Hypoglycemia, B. Suicidal thoughts, C. Severe depression, D. Schizophrenia. The correct answer is A. There are numerous physical problems that can cause bizarre behavior, such as hypoglycemia, hypothermia, and brain tumors, or among others. The EMT should rule out an underlying medical cause first. The patient's pallor, diaphoresis, and motor tremors suggest hypoglycemia. The EMT should assess the patient's blood glucose level, if trained to do so, and consider administering oral glucose. Psychiatric illnesses such as clinical depression and schizophrenia cannot be ruled in or out in the field. Answer A is the correct answer. Answer B. This is a symptom, something that the patient tells you. It does not produce visible signs. Answer C. Depression cannot be ruled out in the pre-hospital setting. Schizophrenia cannot be ruled out in the field. Review question 10. Which of the following signs is least indicative of a person's potential for violence? A. A patient appears tense and edgy. B. The patient is 6'5" tall and weighs 230 pounds. C. The patient is loud and shouting obscenities. D. The patient is facing you with clenched fists. The correct answer is B. When assessing a patient's potential for violence, you should observe for suggestive physical activity, such as clenching of fists, glaring eyes, shouting obscenities, and rapid, disorganized speech. There is no correlation between a patient's physical size and his or her potential for violence. Answer A. This is a signal of possible physical aggression and anger. Answer B is the correct answer. Answer C and D are both signals of possible physical aggression and anger. Okay, class, this concludes the lecture on Chapter 22, Psychiatric Emergencies. Thank you for listening. If you have any issues or questions, please contact your instructor, and I will see you in the next chapter.